Hello, everyone, and welcome to this ANMS Clinical Virtual Symposium. Thank you for attending this meeting and supporting our webinar series. I think the series has been very successful over the last few years, and I hope you enjoyed them. I'm Phoebos Christofi, and I serve as treasurer on the ANMS Council. I serve as one of the basic science editors for neurogastroenterology and motility, and I do research on neuromodulation in the field. For your information, the editors are working on a special issue on enteric neuropathies from basic science to clinical practice, and I hope you find that of interest going forward. So I was really thrilled to be invited to introduce this clinical symposium. Before I introduce our moderator, Dr. John Rosen, for this session, there are updates, programs, and events supported by the ANMS that I'd like to briefly highlight. First of all, our president is Nick Verne, and our new president-elect is Adele Barusha. We have 4 new council members as well: Andrea Shin, Elise Thakur, Nitin Ahuja, Rachel Rosen. Our congratulations go out to all of them. We have coming up the ANMS annual meeting in August in Austin, Texas. What a great location for this event. If you attend, you can look forward to the Young Investigators Forum that's intended to develop future researchers. There's also the clinical course that's always great and well received. It provides best care for our patients. There's a scientific program that's packed with cutting-edge research, some distinguished lectures, oral and poster presentations, and a distinguished Investigator Award for Women in Neurogastroenterology and Motility, and Women's in Neurogastroenterology Networking. We also offer ANMS grant opportunities for clinician scientists and basic scientists, including the ANMS Discovery Grants and a transitional grant. Deadline is October 2nd. We also have ANMS Ironwood Diversity, Equity, and Inclusion Award, and started a couple of years ago, and the deadline is June 1st. Our mini sabbaticals have a rolling deadline. And now it's really my privilege to introduce this ANMS Clinical Virtual Symposium on cannabinoids and psychotropics in the GI tract. I think it's an exciting virtual symposium that I hope will generate a lot of interest and discussion surrounding the use and actions of cannabinoids and psychotropics in adults or children in disorders of gut-brain interactions and treatments. We have 2 outstanding speakers, Dr. Thangam Venkatesan and Dr. Yacob. And now it's my privilege to introduce our moderator for today's session, Dr. John Rosen, who is a pediatric neurogastroenterologist. He serves as the director, telemedicine and outreach, and chief of gastroenterology and nutrition at Children's Mercy Hospital in Kansas City. He holds the academic title of Professor of Pediatrics at University of Missouri, and his clinical research interests focus on disorders of gut-brain interactions and use of telehealth to expand the research of high-value subspecialty care to those who normally have more limited access. I'm really looking forward to this symposium. And John, I will now turn it over to you.
Thank you, Dr. Christofi. I am excited about this as well. It's going to be a great webinar. And thanks to ANMS for hosting and giving me the chance to moderate. And a special thank you to our speakers who I will introduce. And thanks to everybody who's watching and learning. Our first speaker tonight is Dr. Thangam Venkatesan. She is Professor of Medicine, Director of Neurogastroenterology and Motility in the Division of Gastroenterology and Hepatology at The Ohio State University. The primary focus of her clinical and scientific work is in cyclic vomiting syndrome and the role of cannabis and the endocannabinoid signaling in CVS. She's involved in multiple key trials and studies in CVS, including several publications, and serves as the lead author on the first ever guidelines on the management of CVS. She's also co-editor of a book on cyclic vomiting and cannabinoid hyperemesis, which provides the latest research on CVS and CHS, and she's authored several other book chapters on these topics. She's an invited speaker to multiple national and international meetings in her field based on this expertise. On a personal note, she's a long-term meditator and a certified heartfulness meditation instructor. She's also an avid gardener and loves to travel with her family and friends. Before we begin the first part of our webinar tonight, there is time set aside for Q&A at the end of the second presentation. So no questions between presentations. And there should be a link at the bottom of your screen. Please enter your questions in the Q&A section of the Zoom screen, and then we will get to those at the end of the second talk. So Dr. Venkatesan, if you want to kick it off, that would be great.
All right, thank you for that kind introduction. I think hopefully everybody can see my screen. And yes, I'm a gardener. I just want to say that I don't grow weeds, so this particular picture is not from my garden. But without further ado, I think this is a very important topic, really, because of the increasing legalization of cannabis. And today our learning objectives will be to discuss cannabis use patterns in the US. I'm going to talk a little bit about endocannabinoid signaling and gut-brain interactions, specifically vomiting, discuss the beneficial and adverse effects of cannabis use, and I'm also going to talk a little bit about cannabinoid hyperemesis syndrome. So why are cannabinoids important? I think marijuana has really gone mainstream, and it has been legalized in most states now in the US for both medical and recreational use. As you can see on the map, there are several states where it is legal for medical use and also for recreational use. This looks at the prevalence of cannabis use by age from 2002 to 2019, and you can clearly see that there is a striking increase in the prevalence of cannabis use in ages 18 to 25. And this is a graph that shows the increase in cannabis use for those age above 26. And this is the prevalence of cannabis use by sex. And so you can see that it's actually increasing both in men and women. What about the perceptions of cannabis use? Unfortunately, what has happened is that most people do not believe that cannabis is harmful, and they don't really perceive it as a great risk. So again, if you look at this graph from 2002 to 2019, and this is data really for US adult residents, most people really don't perceive it to be harmful, and in fact, they think it's beneficial to their health. And what are cannabinoids? So cannabinoids are essentially compounds that have affinity for cannabinoid receptors. There are different types of cannabinoids. You have something called phytocannabinoids, and then you have endocannabinoids or synthetic cannabinoids. So phytocannabinoids are actually those that are derived from the cannabis plant, which has been around for a very long time, since really 4,000 to 5,000 BC. And there are even reports of the gods using an elixir of cannabis. And there were some very important discoveries that were made in the 1960s. So cannabidiol was discovered in 1963, THC in 1964. And then finally, the receptors were characterized in the 1990s by this person called Raphael McCollum, mostly, who's done a lot of work on cannabis and is really considered sort of the father of cannabis research, if you will. And I think with these discoveries, we have learned a lot about how cannabis and marijuana can affect the human body. In general, phytocannabinoids, as I said, are plant-derived. They're derived from two species, Cannabis sativa and Cannabis indica, and they contain many compounds. But the most important compounds that you really need to know about is THC, or delta-tetrahydrocannabinol, which is psychoactive, and CBD. CBD is actually not psychoactive, and CBD actually technically is not a cannabinoid because it really acts on 5-HT1A receptors. And why do people smoke it? It's because heating the plant actually causes changes, and so THCA, the precursor, is converted to THC, and CBDA to CBD. The other things you really need to know when you're talking to your patient is it's very important if they're actually smoking it or if they're ingesting it. It can be smoked via joints, pipes, water pipes, and so on. And, these are important because the bioavailability can change depending on how you use the product. And it is also important to know that the risk of physical dependence and addiction increases as your exposure to high concentrations of THC increases. And in general, higher doses of THC can produce anxiety, agitation, paranoia, and even psychosis in patients. And in general, it's a biphasic that has a biphasic effect. And in fact, higher doses can result in hyperemesis or lead to hyperemesis. It's also very important to know what type of product your patient is smoking, if they actually know it. So there is something called cannabis concentrate, which refers to solvent-based products where the THC levels can be very high, and they can even be anywhere from 54 to even 80%. So it's very important to ask your patient if they're using cannabis concentrate versus a regular joint. For instance, a regular joint will contain about 15% THC versus cannabis concentrate. This is also a very important graph that I'd like to emphasize. And if you look here, the concentration of THC in a joint is about 4%, and this was around 1995. And if you look at it, it has steadily increased to 15%. Similarly, if you look at it, the concentration of CBD has actually gone down in a joint. And so this has really changed the chemical composition of the product that is being used currently. What about endocannabinoids? So endocannabinoids, essentially, as the name implies, are those that are synthesized in the human body. You have two types of endocannabinoids. They're called anandamide and 2-AG. There's specific receptors, CB1 and CB2, and then enzymes called FA and MAG lipase. And this actually refers to the distribution of cannabinoid receptors. And as you can see, they're actually widely distributed. They're present in the brain. They're present in areas that are important for nausea and vomiting. And they're also actually situated or located in the GI tract. And so they really play a very important role in stress, nausea, vomiting, inflammation, and so on. And what happens and why is endocannabinoid signaling important? So this is actually very important for homeostasis and regulation of stress. And we experience stress on a day-to-day basis. And so when somebody is stressed, what happens is there is a production of endocannabinoids, and this acts on CB1 receptors. And I would like to point out that cannabinoid receptors are actually present on the presynaptic terminal as opposed to the postsynaptic terminal. And this actually will inhibit neurotransmission and ultimately brings the host back to homeostasis. And this is another diagram which shows how endocannabinoids are important in visceral pain. So what happens is, a lot of patients may ask you, how is chronic stress related to my pain? And there is a direct connection. So when you have chronic stress, it actually can turn on certain genes. And what happens is there's epigenetic modification of what we call cannabinoid CNR1 genes. And what results is that this can act on certain receptors that are present in the dorsal root ganglion. And as a result of which, there's actually an increase in TRPV1 receptors, and there is a decrease in CB1 receptors. And so there's actually increased pain transmission. And so a patient can actually feel pain because of chronic stress. Now, what about cannabinoids and IBS? It's also related with IBS, and there are certain studies which have shown that there are certain CNR1 and FA variants which have been associated with IBS. Cannabis has been shown to slow motility and reduce cramping, so certainly there's potential in use in IBS diarrhea. FA inhibitors, so FA is the enzyme that actually breaks down the cannabinoids. So if you have FA inhibitors, you can increase endocannabinoids and you can have antidiarrheal and antinociceptive effects. But things are not so simple. So some of these products actually have other systemic effects or off-target effects. And so some of these studies have shown that they have actually adverse cardiovascular effects. And so I think, why we really need to do a lot of research before these agents can be used in clinical medicine. And again, CB1 antagonists can cause diarrhea. So certainly there are potential applications of cannabinoids in GI disorders. A lot of patients will tell you that they use cannabis to improve their appetite. And it is true. There are multiple studies showing that they actually, quote, lead to the munchies, as they are called. They're very important in nausea and vomiting. So cannabinoids do have anti-emetic effects, and it has been shown in multiple preclinical studies and clinical studies that it actually inhibits emesis, which are evoked by both central and peripheral stimuli. And CB1 receptor antagonists can actually initiate or potentiate emesis. And cannabinoids have been used as antiemetics, and these are synthetic cannabinoids. I think we're all familiar with nabilone and particularly marinol. And there is a systematic review of almost 30 clinical trials where these agents were found to be superior to dopamine receptor antagonists, particularly in chemotherapy-induced nausea and vomiting. They were as effective in preventing nausea, and it was as effective as ondansetron in treating chemotherapy-induced nausea and vomiting. However, I will say that these are all very old studies, and they certainly have much better antiemetics at this point. Now, there is another agent called Sativex, which is half THC and half CBD, and this is actually delivered as an oromucosal spray. And so it really reaches maximal plasma concentrations within 2 or 4 hours. It is less rapid than smoking cannabis, but it has been shown in studies to reduce the incidence of delayed chemotherapy-induced nausea and vomiting compared to placebo. Now, this was what is called a skinny pill. It was called Ramonaban, and this was actually a CB1 receptor antagonist. And if you remember, I said that an agonist can cause the munchies. So an antagonist was thought to be an effective weight loss agent, and in fact, people were losing weight. Unfortunately, it was withdrawn from the market in 2008 because there was an increased risk of depression, and it resulted in vomiting. Again, there are certain CNR1 receptor polymorphisms in cyclic vomiting syndrome. This is a case-controlled study that we did, and we found that there were certain polymorphisms that were associated with the risk of CVS, and there were certain polymorphisms in the CNR1 gene that were actually associated with a positive response to therapy. And so I think we know that, endocannabinoids now are good for you. And perhaps weed is also, been reported to have all these good beneficial effects. But then we do know that this cannabinoid hyperemesis syndrome has been talked about a lot. And so let's look at whether the data really kind of shows that it has adverse effects. And so what are the problems with cannabis? One of the problems with cannabis, if you can see from this graph, is that this was actually a study that was done in Colorado. And if you look at the blue lines, it shows out-of-state residents who actually come to Colorado to really use marijuana because it was first legalized in Colorado in the US. And you can find that there was actually an increase in ED visits for vomiting due to this marijuana tourism, if you will. And again, it's unclear if there was a true increase in vomiting due to cannabis use, or whether it was because they did not really recognize the pattern of cyclic vomiting syndrome. And so, there is certainly other data as well showing that presentations with cyclic vomiting increased following marijuana liberalization in Colorado. What is cannabinoid hyperemesis syndrome? So cannabinoid hyperemesis syndrome is defined, this is actually the Rome-4 definition, Rome-4 criteria for CHS. It's pretty much very similar to CVS, and it consists of stereotypical episodic vomiting, and it usually should present after prolonged excessive cannabis use, and there should be relief of vomiting episodes by sustained cessation of cannabis use. And it may be associated with pathological bathing behavior. And so I think this term was coined initially based on some retrospective chart reviews and a large case series of 98 patients. And they said that there was an association with chronic regular cannabis use. There was a long duration of use preceding onset of symptoms. But the problem with many of these is there was barely any follow-up in these cases. And so we need to ask these questions. Is it distinct from CBS? And does it really exhibit different epidemiology? What about this hot water bathing behavior and specific therapy? So this was actually a cross-sectional study that we performed of patients with CBS in my clinic. And we looked at cannabis use patterns, and I will say this is really the, one of the few studies that actually used a validated questionnaire to look at cannabis use patterns. And so if you look at this pie chart, really most patients, about 59% of patients never use cannabis. And then 22% of patients did use cannabis 4 or more times a week. And so really, it's really those patients I think we need to be more worried about rather than those who use it monthly or occasionally. And we asked these patients what cannabis used it to them. And in fact, they said that it actually improved their symptoms, including vomiting, abdominal pain, it improved their appetite, and they also said it reduced ED visits and hospitalizations. And a proportion of patients said that they were able to continue working and also able to continue their studies as a result. And when we looked at these patients, most of them had tried abstaining from cannabis for at least a month, though this is not long enough. And there was only one patient who actually had resolution of symptoms when they stopped cannabis. And this person actually subsequently resumed cannabis use with more CBD, and he remained symptom-free despite using a cannabis product. And I think longer follow-up is needed to tease this out. We also did a systematic review looking at all the cases really of CHS. So we looked at about 105 individual cases, 25 case series. And, this is important. So when we looked at this, albeit many of these case series and case reports were purported CHS, were really published prior to the Rome criteria. And so when we tried to apply the Rome 4 criteria retrospectively, we found that only 14 to 20% of these cases of CHS really met Rome 4 criteria. And most of the case reports really did not have much follow-up. In fact, there were only about 16 to 25% of cases who had follow-up of at least 1 month. And so really it calls into question as to whether these patients actually had cannabinoid hyperemesis or whether they had CVS. And many of these diagnoses were made just based on hot water bathing. And this is actually not pathognomonic of CHS because it can also occur in about 48% of CVS patients who don't use cannabis at all. And so, what are the potential causes of hyperemesis? It's possible that, as I said, I showed you some data showing that there might be a genetic predisposition. Certainly, we also have some data that there could be potentially a relative endocannabinoid deficiency. So you really need endocannabinoids to stay in homeostasis. And so we do have some data to show that this might be the case. And again, like I said, the potency of cannabis products. The cannabis products that are available currently have a very high THC content as opposed to CBD. And certainly this is also a significant problem because we are dealing with a completely different product. And this might also lead to hyperemesis. And so I think, really there's not a whole lot we know yet or understand fully about this disorder and how cannabinoids affect GI health. But I think we need more systematic studies to really answer these questions. And again, thank you for having me. And I would like to acknowledge some of these people who are my mentors and friends. And, the picture here is of Kathleen Adams, who was the president of the Cyclic Vomiting Syndrome Association and ran it for almost 30 years. So thank you.
Thanks, Dr. Venkatesan. That was amazing. And I have so many questions, but like everybody else, I will wait till the end. Don't forget, put your questions in the Q&A box so that we can ask them of our speakers at the end of Dr. Yacob's talk. Our second speaker this evening is Dr. Desale Yacob. He attended the University of Virginia for both college and medical school, and then completed his pediatric residency at the Children's Hospital of King's Daughters in Norfolk, Virginia. He went on to complete his pediatric gastroenterology fellowship and motility training under Dr. DiLorenzo, who I think is in the audience tonight, at Nationwide Children's Hospital in Columbus, Ohio. And he joined the faculty there in 2009, currently an associate professor of pediatrics at The Ohio State University College of Medicine. He's the medical director of the Center for Neurogastroenterology and Motility Disorders and the program director of their Motility Fellowship. He's published close to 40 peer-reviewed journal articles, many book chapters, and he enjoys painting, spending time with his family, socializing with colleagues, and running. Dr. Yacob.
Well, hello, everyone. I would like to also thank ANMS for the invitation and Dr. Rosen for the introduction and all of you in attendance for joining us today. It is not easy to follow the good Dr. Venkatesan, but it is an honor to be her co-presenter. The chosen title for my talk is Psychotropics in the GI Tract, but all right. So the chosen topic of that title for my talk is Psychotropics in the GI Tract, but I would prefer that it be changed to Neuromodulators in the GI Tract in order to be compliant with the new terminology or GI terminology to describe this medications. So my objectives are, one, to define the mechanism of action of central neuromodulators, two, to discuss their role in treating disorders of gut-brain interactions, and finally, to describe the process of identifying patients suitable for therapy with these neuromodulators. So the dictionary defines psychotropic as an adjective relating to or denoting drugs that affect a person's mental state, and Wikipedia actually describes it as a psychoactive drug taken to exert an effect on the chemical makeup of the brain and nervous system, and that medications in this class are used to treat mental illnesses. So it is not surprising that the word psycho in psychotropic is not well received by our patients. So just like the term disorders of gut-brain interaction has replaced functional GI disorders, relabeling of psychotropic medications and referring to them as gut-brain neuromodulators is more appropriate, both from a scientific and patient care standpoint. So gut-brain neuromodulators include centrally active drugs, such as antidepressants, antipsychotics, and others, as well as those that act peripherally, including serotonergic, chloride channel, and alpha-2 delta ligand agents. Interestingly, it is not just patients who struggle with accepting these medications as viable and safe treatment options. A study conducted by Nielsen et al. Surveyed gastroenterologists in the US on the use of central neuromodulators for treating IBS. The perceptions amongst general gastroenterologists and GI experts who are active in the care of these patients are shown in this table. When it comes to the importance of using these drugs, over 50% of gastroenterologists say they are very or extremely important. Regarding competence with this drug, 60% of the gastroenterologists surveyed indicated low to moderate competence, which is different from the expert provider group with 90% reporting high competence. So what are the factors that make people scared of these drugs? So factors limiting GI providers from prescribing central neuromodulators to their IBS patients range from concerns about needing to address side effects to being uncertain which drugs to use, also to being unsure if patients will get on board. So how do we get more comfortable with these drugs and increase their utilization? Understanding their mechanism of action, for one, being able to discuss their therapeutic benefits and potential side effects are also as important. When it comes to the case of central neuromodulators, they interfere with the function of pain-related brain circuits through their monoaminergic actions, interfere with complex mechanism of pain transmission, and exert profound effects on peripheral GI physiology. And that's where their role in GI symptoms and treatment of GI symptoms comes from. So most of the currently available antidepressants work by blocking the presynaptic reuptake pumps of the main monoamine neurotransmitters, mainly the serotonin, noradrenaline, and dopamine neurotransmitters. As a result of this blockage, neurotransmitters will accumulate in the synaptic cleft, which in turn leads to a delayed downregulation or desensitization of postsynaptic receptors with antidepressant or neuromodulated effect. So tricyclic antidepressants, which are some of the most common ones, act as both a serotonin and noradrenaline receptor inhibitors, along with playing an antagonistic role on additional post and presynaptic receptors. These medications include the tertiary amines of amitriptyline and imipropine, and these are the ones that have anticholinergic effect. And the secondary amines of desipramine and nortriptyline, and those do not have anticholinergic effect, which is very important to know when you're trying to choose which medication to use. When it comes to their actions on the GI tract, they have been reported to slow transit, and there is limited evidence that they decrease visceral sensitivity. The next slide will address possible side effects of these drugs, but it is important to note that some of their side effects are actually useful in addressing disorders of gut-brain interaction symptoms that patients may present with. As an example, an anticholinergic effect of a tertiary amine, such as an amitriptyline, will actually be helpful and is effective in treating diarrhea in patients with IBS. The additional receptor affinities of tricyclic antidepressants can cause several side effects, and anticholinergic side effects of dry mouth, constipation, drowsiness, and blurred vision develops as a result of the muscarinic 1 receptor antagonism, while the alpha-1 adrenergic receptor antagonism results in dizziness, drowsiness, and orthostatic hypotension. And the histamine receptor antagonism causes weight gain and drowsiness. And that in itself could be something that you could make use of if you have a patient who is struggling to gain weight or is having issues with sleep at night. One of the most serious side effects of the tricyclic antidepressants results from the sodium channel blocking properties and can potentially cause arrhythmias, coma, and seizure. So tricyclic antidepressants should therefore not be used in patients with bundle branch block or prolonged QT intervals. And at least in our practice, we routinely get an EKG in patients that we are planning to start them on one of these medications. When used for GI tract neuromodulation, the doses are lower than used for psychiatric purposes. And that is something that actually is very helpful because the side effects that are seen in patients who are treated with these medications for psychiatric purposes are not typically seen in our GI patients. And it's also always good to start with the lower doses and get the doses to go up if needed. So there are not that many pediatric randomized prospective trials using central neuromodulators, but this multi-center randomized placebo-controlled trial of amitriptyline in children with pain-predominant functional GI disorders, which was done or published in 2009, is one such study. And it showed that there was no statistically significant difference between the treatment and placebo groups, and amitriptyline did reduce anxiety significantly compared to the placebo. One thing that is worth mentioning here is that the study duration was only 4 weeks, and the outcome may have been better or different if the treatment period was much longer, knowing that these medications have to be on board for much longer period of time to really effectively do the neuromodulation that we are looking for. So the selective serotonin receptor inhibitors are another group, and they are characterized by their selective blockade of the presynaptic 5-HT receptor transporter, boosting the serotonin transmission, neurotransmission. The primary serotonergic effect without noradrenergic effect leads to greater benefit in treating anxiety, obsessive compulsive disorder, and phobic behaviors. They are also less helpful. They are less helpful for chronic painful symptoms or disorders, but these medications are medications that could really be very beneficial because they do not have the type of side effect profile that the TCAs do. So the SSRI drugs include citalopram, escitalopram, fluoxetine, paroxetine, and sertraline. As it has been mentioned, they are presynaptic serotonin reuptake inhibitors, and they are reported to have an enhancing effect on the gastric and small bowel motility, but no major impact on visceral sensitivity. They are most effective in treating associated anxiety, compulsive disorders, and phobic traits. Again, being familiar with the side effect profile of these drugs is important, and SSRI are known to cause agitation, diarrhea, insomnia, amongst others, but not side effects as serious as the ones that TCAs make. The class of drugs, this class of drugs is different from the TCA or SSRIs because their action is based on partial agonistic mechanism for the pre and postsynaptic 5-HT1. They're reported to have enhanced esophageal contractions and increased gastric accommodation in health and in patients with functional dyspepsia. They have a role in treatment of anxiety, early satiety, fullness, and nausea. Sedation, headache, and vertigo are possible side effects, but like medications like buspirone are medications that could be really helpful, and they can come handy in patients with functional dyspepsia. So gabapentin, pregabalin are both delta ligand agents and are mostly regarded as peripheral neuromodulators. Their mode of action is blockage of voltage-sensitive calcium channels. These are medications with potential use for treatment of neuropathic pain in disorders of gut-brain interaction. Sedation, headache, vertigo, weight gain, and peripheral edema are some of their side effects, and one should be aware of the side effects. But as in any of the other medications, the dosing that you start with are lower than if they were being used for other purposes. So here is a good summary of the different classes of gut-brain neuromodulators for patients with DGBI diagnosis. I already mentioned the selective serotonin receptor inhibitors and the TCAs, but the other medications are the tetracyclic antidepressants like mirtazapine and the SNRIs, the serotonin adrenergic receptor inhibitors. These medications can be helpful in pain predominant DGBIs or when side effects from TCAs preclude the use of the TCA medications. But what if you're using one of these medications and you're not really getting the kind of results that you want to get in your patients? So that's when augmentation comes in very handy. And augmentation treatment should be considered when a single treatment is not adequate, is not tolerated by the patient, or is causing side effects. Here are the different ways one can do augmentation therapy. You can add azathioprines in patients with dyspeptic features or have anxiety as a prominent symptom. You could add one of the delta ligand agents, such as gabapentin, which can be helpful in patients with severe visceral hyperalgesia, or in patients with fibromyalgia, which is not uncommon to see comorbidity in this patient population. Atypical antipsychotics for disturbed sleep and additional somatic symptoms, and bupropion can be helpful with fatigue and sleepiness, or when fatigue and sleepiness are prominent. As far as I'm concerned, psychological treatments such as cognitive behavioral therapy should be brought up as part of the initial therapeutic plan, and we should not wait to think of that approach until there is a need for augmentation. So here, not everybody who comes to a clinic will need to be on a neuromodulator. We all know that this is the presentation of patients with disorders of gut-brain interaction is a spectrum. So here you have a 14-year-old patient who complains of intermittent abdominal pain, is attending school, playing sports, hanging out with his friends, does not require neuromodulation as far as I'm concerned. This is a patient who is functioning perfectly well. He does have these symptoms, so it has to be acknowledged. It has to be addressed. And one of the most effective things to do for this patient is discuss the diagnosis and give him the diagnosis on that first visit and provide reassurance with some as needed antispasmodic medications that he could take if his symptoms are keeping him from doing things. But this 18-year-old patient presents with frequent periumbilical abdominal pain, constipation, and relief after defecation has been missing school on a frequent basis. There is no history of anxiety or depression, but he is stressed by his symptoms, and he has not tried any treatment until he saw you in clinic. He may benefit from a good bowel regimen and peripherally acting neuromodulators such as dicyclomine or hyoscyamine. Will also be a good candidate for linaclotide, which has the dual benefit of treating constipation and IBS-related pain. He may also benefit from cognitive behavioral therapy if available. And this last patient is severely disabled, and it's not uncommon to see patients coming to clinic with significant symptoms that is very disabling. She has symptoms of diarrhea, predominant irritable bowel syndrome, functional dyspepsia, and is unable to attend school, socialize, or do anything that requires physical activity. This is the kind of patient who will benefit from central and peripheral neuromodulators and cognitive behavioral therapy, as well as physical therapy, and maybe even services from a social worker to make sure that she is able to be integrated back to her normal activities. So how does one figure out which patients are going to need which kind of approach? So the multidimensional clinical profile, or MDCP, actually provides case-based examples that help clinicians understand the full dimensionality of the patient's symptom experience. It serves as a GPS or roadmap and guides the clinician to produce targeted treatments, especially the patient is when the patient is presenting with moderate to severe symptoms and will be needing a comprehensive plan. So the profile is made up of 5 parameters. You have to give the categorical diagnosis based on Rome 4 criteria, a clinical modifier such as symptoms or features additive to the initial categorical diagnosis, impact on their daily activities. This is actually very important because this is what really determines whether this patient is presenting with mild, moderate, or severe symptoms. If patient illness perception, behaviors, and daily functioning, so mild are key things to focus. Psychosocial modifiers are just as important as well. Psychiatric and psychological symptoms or syndromes such as anxiety, depression, excessive worry, and major stressors, and physiologic modifiers of visceral functioning and biomarkers. These are what you will get out of a workup that you will do in a patient that you're seeing for the first time. So slow transit constipation, delayed gastric emptying are some of the examples. So as a patient case, this is an 18-year-old female who presents with a 6-month history of intermittent periumbilical abdominal pain. The pain is accompanied with and relieved by a bowel movement that is frequent and loose. She also has symptoms of nausea, early satiety, and epigastric abdominal discomfort, leading to a 5-pound weight loss. Her illness has impacted her school attendance and participation in sports. The patient and 2 other family members experienced an acute febrile illness with vomiting and diarrhea lasting for a few days, around the same time that she started having her current symptoms. Socially, she recently went through a breakup with a boyfriend, and her parents divorced about a year ago. She does suffer from anxiety in addition to the symptoms. Her workup consisted of CBS, SED-rate, chemistry, lipase, celiac, serology, stool calprotectin, and an upper endoscopy is unremarkable. So when you take this patient and you put together a multi-dimensional clinical profile, a categorical diagnosis is irritable bowel syndrome and functional dyspepsia. A clinical modifier of post-infectious IBS with diarrhea and epigastric pain syndrome is something that goes along with that. And the impact on her daily activities, moderate to severe. She is not attending school, and she's not taking part in sports, and she's not socializing. The psychosocial modifiers, social anxiety, stress, parental divorce, and recent relationship breakup are things to note, but her workup was perfectly normal. So how do you approach, or how do you come up with an effective plan for this patient who is quite disabled by her symptoms? So this is someone who could actually benefit from a tricyclic antidepressant, starting with an amitriptyline at 25 milligrams daily. But before you proceed and do the initiation of the amitriptyline, an EKG to screen for QT prolongation may be very helpful. At least in our practice, we routinely do that. So low to modest dosages of tricyclic antidepressants provide the most convincing evidence of benefit for treating chronic gastrointestinal pain and painful FGIDs, and should be continued for 6 to 12 months to potentially prevent relapse and to effectively get her back to her baseline. Augmentation treatments for her, citalopram will be an excellent choice, or any of the SSRIs, because she has significant anxiety. Supraheptidine for functional dyspepsia, to treat the early satiety, nausea, and the epigastric discomfort. But there are also other medications that you could consider. But we find supraheptadine to be very helpful in this kind of situation. And cognitive behavioral therapy should be initiated at the beginning. So in summary, psychotropics should be referred to as gut-brain neuromodulators. An effective patient-provider relationship and physician comfort with these drugs are key ingredients in the utilization of these drugs. Augmentation is recommended when a single medication is unsuccessful or produces side effects at higher dosages. And multidimensional clinical profile is a helpful clinical tool that facilitates a comprehensive therapy plan. Neuromodulators should be on board for up to 6 to 12 months for effective modulation and prevention of relapse. Thank you, everyone. And please don't forget to join us in Columbus, Ohio for the Second World Congress of Pediatric Neurogastroenterology and Motility come September 7 to 9 of this year.
Thank you so much, Des. Please put your questions in the Q&A box. And I have a question for you just leading off from your talk. And Thangam, thanks for joining us again, too. So Des, with these medications available and certain clinical scenarios where they should be prescribed and maybe helpful as part of the plan, should it be only neurogastroenterologists prescribing these medicines? Should family doctors or general GI doctors? How do we decide? And then are there times where you as a neurogastroenterologist say, this is beyond me, I need a pharmacologist or a psychiatrist or somebody else maybe with more expertise in these medicines to help out?
Oh, John, you bring up a very, very important question, because I will confess until recently, I used to discuss with patients and say, you have anxiety, make sure that your primary care physician prescribes you some kind of medication to address that. But eventually we realized that these patients are not going to just go to their primary care physician and get the right medication. So there has to be some comfort level. And I think we have to take a responsibility for these medications. So as to whether it should be just a neurogastroenterologist or just a general gastroenterologist, I think we should all be comfortable with these medications. We have to choose at least one drug from each class that we could be comfortable with. And the fact that these patients are seen by all of us is another reason why we should all be spending time to get to understand these drugs and to have a better comfort level so that we could truly take care of these patients and effectively treat their symptoms.
Thank you. There is a question from the audience for Thangam. How do we determine what a patient is taking in terms of THC, CBD? Do we need to, and how is this possible?
So I think actually, that's a good question. And they also talked about the urine tox screen. So, one is actually ask the patient. And unfortunately, the cannabis products are really not well regulated at all. Like you have, Delta 9, you have Delta 8, you have so many things, and we don't know what the ratio of CBD and THC is. So marijuana actually has both THC and CBD, but it can be in varying ratios. And it really depends, for example, if somebody is smoking a joint, the amount of THC will be less, like I said. If somebody is using cannabis concentrate, then the amount or the proportion of THC concentration will be very high. So one way to at least judge somewhat is to ask them, like I said, what type of cannabis product they're using. So that can give you a little bit of an idea. Now, some people actually use pure CBD products, and they will tell you that. CBD is really not regulated at all. And just knowing from some of the researchers, in fact, in Colorado, there were people who were selling CBD gummies way back, and they actually contained THC, and mothers were giving them for epilepsy. And then they came out with regulations saying, well, you cannot sell cannabis products like gummies because it gives this sort of innocuous impression. So I don't think we really have a good answer. The other thing about the urine tox screen is Even if a patient, say, quits cannabis, it can actually be stored in adipose cells, particularly with heavy users, and it's slowly released. So tox screen can actually be positive even after a patient has quit. And the best way is to sort of ask them, and I don't think we have any really good clinical tests available at this point. And I think both regulation and developing better tests to quantify this, are needed.
And we have time for a couple more questions. I did have a question maybe for both of you, but Thangam, you could take this first. Recreational marijuana has been legalized in Missouri, as you showed on your slide. Lots of states are doing that for patients or for anyone 21 and up. And it may be different in adult and pediatric medicine. I know we have a hospital staff, hospital council special session directed at what they expect or what is allowed in terms of both use and recommendation for treatment. Is this something that you've encountered in terms of it's out there? What are you allowed to do from a hospital perspective compared to a legal perspective? And how should doctors look into that? How important is that?
Yeah, I mean, that's a very good question. And I think one is, unfortunately, the legalization of cannabis has outpaced research. So we don't have really, good data. And if you look at cannabis products, really it's FDA approved only for chemotherapy-induced nausea and vomiting and really wasting from AIDS syndrome, which you really don't see so much at all. And then there's a smattering for, epilepsy and so on and so forth. So I think, when we confront a patient, particularly in GI outside of this, it's not really kind of approved for any of these GI disorders. And then I think, particularly in adolescents and children, unfortunately, even though they have legalized it, there's data to show that it has adverse effects on a developing brain. It's been associated with reduced brain volumes. And so it really alarms me when somebody comes in who's younger. There's neuroplasticity and so on. And that alarms me more when I have a younger patient than perhaps somebody who's older. And so I think we don't have it yet. And there's no clear guideline that you can actually send a physician or even a patient to, and there's not enough data or research. So until all of that happens, we really don't have as much clarity. But certainly daily or near daily use, I think, is harmful. And I will kind of at least advise my patient about what is known.
Des, is that the same experience in pediatrics, or I don't know the status in Ohio, if that's a situation you've encountered with patients coming in already using and you have to identify and advise related to their medical condition? I think you're muted still.
No, I think it's not any different than what Dr. Venkatesan said.
Great. There's another question in the chat. Thank you for putting that in. And if we don't know exactly what a patient's taking, what research is needed, and can we measure this? And I think this gets to the question of specificity. So you talked about the broad effects of some of the gut-brain neuromodulators, the broad effects of some of the cannabinoid different delivery agents, how much THC, CBD, what receptors they're active on, and really a lot of those have broad effects. So is there a way to know, one, like what they're taking, you ask them, but how that's affecting their body, and what research in particular should be directed towards this? Should it be finding more selective agents, or how to identify those selective agents? Or is there a different pathway we should be taking in figuring out which agents can be most effective and used to help our patients?
Yeah, I mean, that's such a broad, it's very difficult to answer that question, because when you say, oh my God, what research, there's like, really a million things, that come to mind. I mean, clinically, I think most commonly is the urine kind of tox screen. I know there are some of the ways that where you can actually get hair samples of people now. I guess if they're bald, it's difficult. But you can actually, quantify THC and hair samples and so on, but that's not done really clinically. And in terms of like CBD and THC and so on, I am not aware, of anything specific that's being used clinically at this time point. I could be wrong, but I'm not aware of anything in clinical use. And I think, for instance, when we talk about a product, for instance, you go buy Tylenol, there's 500, milligrams of Tylenol, but you don't know that. And so I think, unfortunately, even though they've legalized it, they haven't regulated it at all. And so I think really the manufacturers and people who sell these things, the consumer needs to know exactly what they're consuming. And, it's not as easy. For example, some people inhale it, some people ingest it. If you use an edible, it has lower bioavailability than if you inhale it. And all we know is that, in terms of inhaling it, you can inhale large quantities of THC very quickly, and that can be a problem. So there's a lot of unanswered, questions, and there's really a lot of research to do. So we've got to start somewhere. And there isn't really a whole lot of funding that's actually been allocated for these disorders.
Thank you very much. And I would encourage you to ask more questions of the panelists, of the speakers, who would be happy to answer these. We're at the end of our session for today. So thank you once again to ANMS for hosting the webinar, of course, to the speakers who provided all this great information and answers to the questions, and to the audience for attending. And any questions that you have can be addressed later through Doc Matters as well, with the website here. And the recording itself will be edited and posted later to ANMS YouTube channel. Thank you again.